Liliana Johnson. Now, the next 60 minutes is really best suited for those curious or interested in what QI means. This is not as useful to people who do have a clear understanding of what quality improvement is and how and why it can be used. So just want to make sure that it is useful for your time. NNPHI partnered with Association for Immunization Managers, or for short AIM, to bring a trainer and an immunization manager practitioner who uses QI to increase efficiency and effectiveness at her state health department. I'm going to introduce the trainer, Laurie Call, who you just heard from, then turn the baton over to my colleague at AIM, Beth Rowe West, to introduce the other Lori Linstead, the immunization manager practitioner. Laurie Call is from the Illinois Public Health Institute, provides training and consultation services to partners such as health departments and others in a variety of performance improvement areas, including quality improvement, accreditation readiness, and a whole slew of other performance improvement activities. And can I turn it over to you, Beth, to introduce Lori Linstead?
Sure. Can you hear me?
Yes.
Okay, great. Well, it is my great pleasure to introduce Lori Linstead to you. She is the Immunization Program Manager for the state of Oklahoma. Lori has extensive experience in public health and actually was on the forefront of formation of Smart Start in the state of Oklahoma. And she is passionate about quality improvement. And so we are quite honored and delighted to have her on the call with us today. Thank you, Lori.
All right, I'm going to turn it over to Laurie Call to kick us off.
Great. Thank you, Lil. I really appreciate it. And again, thank you all for your patience. I'm really honored to be with you today and hope that we can move through this presentation and make the best use of your time. So the first question, just to get a handle on who we have on the call, have you participated in a formal QI project before? And this is a poll question, so if you're looking at your screen, you can click yes, no, or unsure, and then we will be publishing those results. So go ahead and enter that on your screen right now, and I'm seeing those responses populate. We have about 170 responses now, and so we're going to stop right here. Looks like 180. Lil, you want to go ahead and close that out? Okay, so 63, almost 64% have, and 34% haven't. And I love those who are just not quite sure because you're learning about it right now. So 2% haven't. So we do have a lot of folks who have experience, and I know that Lil mentioned that this is a very basic introductory course, but I recognize that some of you may want to be tuning in because you're sharing it with your peers and colleagues and you just want to be able to have something to share. So welcome, and we'll just go on to the next slide. We'll have a couple more polls throughout the session, so hopefully that will keep you engaged. So what is quality improvement, or QI for short? It isn't a matter of chance. It really is a deliberate and defined improvement process, and we want to make sure that it's very responsive to our stakeholder needs, our customers, internal and external, and it focuses eventually somehow on improving population health when we're talking about quality improvement in public health. It's continuous and ongoing, and we do this work so that we will see measurable improvements. We will be more efficient, effective, greater performance and accountability, and produce outcomes, all of those things that we can actually measure to show that we have made an improvement, so that we will see increased equity and improved community health. I love to look at W. Edwards Deming quotes, and I think that they really give us a nice insight into what QI really is. And so Deming says that systems are perfectly designed to get the results they achieve. So when we are not happy with the results we're receiving, when we aren't happy with the way things are working, we need to go back and really look at the system, the processes that are in place, and explore those to identify how we can make it more effective and produce the type of results that we want to get. The other quote that I think is really important, none of us are really usually big fans of change, and we experience a lot of change. But in fact, he says that of all the changes he's observed, about 5% were improvements. The rest at best were illusions of progress. So we want to make sure that we are actually implementing changes that are improvements. So the data is really important. So I'd like to ask another question here. What percentage of the changes made at your agency or within your department are improvements that can be proven with data? So is that less than 10%? Is it between 10 and 25%, more like 26 to 50, 51 to 75, or really on the money there, 75 to 100%? We've got about 90 responding. Let's see. See if we can get this up to a 200. Keep them coming. And looks like we're slowing down now, so we'll go ahead and close it out with 170 responses, Lil. Okay, so looks like about, let's see, 54, 55% are under 25%, and there's just a very small percentage who are in that 75 to 100 range. So we know that we're making a lot of changes. We may think they're improvements. We can't necessarily prove that with data. So one of the things quality improvement can really do for us is make sure that we are able to prove that with data. So why is it so important now? I think that you'll all agree there's a variety of reasons why it's important, but definitely we are continuing to be challenged with reduced budgets and demand for more and more with less and less. We also have a really educated group of stakeholders that we work with that are demanding more accountability and want to see results, whether those are investors and funders or even partners. Even our constituents and our community residents and clients are wanting to see more accountability. There's more needs, of course. We also have an aging government workforce and really being able to have that historical perspective of documenting processes and understanding what works. And so it's not left with somebody in that historical file of their brain when they leave. Accreditation is also another reason. There's a need for quality improvement and accountability and performance management through many types of accreditation. So public health really needs to focus on increased efficiency, effectiveness, reaching customer satisfaction or exceeding that, and documenting our best practices in our work. So I'd like to just talk first, differentiate between three important terms, and then we'll spend the majority of the rest of our time on quality improvement. But my colleague Lori is going to share a great example on quality planning and what they did. So let me first introduce to you the difference between quality improvement, quality planning, and quality assurance. And you'll notice that I have several slides here from a great mentor, friend, and colleague and expert in the field, Marnie Mason, out of Seattle, Washington. And Marnie adapted this from Joseph Duran's work, the Quality Trilogy. So I want to take a minute just to explain this. Now this looks pretty complicated and confusing, but I guarantee you it's a really simple explanation here. So in the first column on the left, you see quality planning. And quality planning is when we have either a brand new initiative where we're trying to overhaul something completely because it's just not working and we need to just throw it out and start over. But quality planning is something that we probably have all engaged in at multiple times in our jobs. So it's where we define the opportunity that something needs to be completely overhauled or we need something to start. And we start by identifying what are all the stakeholders' needs related to this. So we need to really understand what the customer's needs are, what the funder's needs are, what the internal staff needs are, what the partners are, et cetera, so that when we're building or designing this program or system, that we are thinking about those stakeholder needs and we're building it based on those stakeholder needs. Then we design it and we pilot test that. So it's just like a new program, a new project, a new system. If you get a new system in to take over something, you're going to pilot test that small scale to see how it's working, monitor it, and be able to collect some data to see what the results are. Is this doing what you wanted it to do? And make those adaptations and take action and continue that cycle. So now we've developed something. And we've developed a system, and we're monitoring the data or the results that that is producing. So if you see the line graph here, you see this red line is going along, and we're now in the quality control zone because we've got this great new program, we've got this great new process, it's producing the results we want, everything's going along pretty steady, and then all of a sudden you see we have this big spike. So when we have a big spike like that, we need to investigate what's going on here. This process is no longer achieving the desired results, so it looks like it's potentially an opportunity for improvement or some sort of glitch. We need to figure out what's going on. So we went from quality planning to quality control, and now we investigate that spike to see what's going on with the data, and we realize this is not just a glitch, this is something that we need to improve. So we go to the quality improvement cycle. When we go into the quality improvement aspect, we're really looking at what's the problem, understanding the problem, understanding the root causes related to that, selecting a potential improvement, testing a solution for that improvement, monitoring that data, and if it works, we're going to adopt that fix. We may need to adapt it or we may need to abandon it, but we have applied quality improvement to get that back on track. And what you see here with the red line is it's not only been back on track, it improved from where we started, and we were able to sustain that improvement because in the fourth and final column on this visual, in the last zone of quality control, we have a really steady line of data that shows a marked improvement, not only from the spike, but from where we started. So this is a visual of how the three components may work together. So you see quality planning, quality control, quality improvement, and then back into quality control. And there's also opportunity for multiple cycles of quality improvement. So you might do multiple rounds of that PDSA. And we're going to explain the PDSA cycle and the model for improvement shortly. Okay, so just to clarify, when do you use quality planning? Quality planning, again, should be used when the service or process has never existed before. It's also important when we don't really know what the customer requirements or expectations are, and we need to define those in order to understand what quality really means. Because quality is ultimately defined and in the eye of the customer. So that might be internal customers who access the process in different ways or get a piece of work from us. It might be funders. It might be the customers that we serve. It could be a variety of those folks. So when we don't know what those needs are and we need to take the time to identify what those needs are, we're really in the quality planning phase. When the existing service or process that you have in place is absolutely not capable of meeting those customer requirements, that's usually a situation where we need to have some sort of overhaul. So that overhaul would put us into the quality planning mode. Also, when there's a service or process that is not done repeatedly, it's more of an ad hoc. It's also extremely variable, and it's not necessarily well defined. Maybe everybody's doing it a little bit differently. It hasn't been worked on before as a whole, only maybe in pieces, and so we really need to look at the whole. So that might be quality planning. It's usually something that we do when there's no performance data that exists or we're not going to be able to collect performance data. Because for quality improvement, we have to know where we're starting. So we have to have some baseline data to understand where we're going. Now, if we can easily collect that baseline data, so for example, let's say that the clinic wait times are extremely lengthy. We may not know the average amount of time, but we could collect that data fairly quickly and understand what the average wait time is in our clinic and be able to apply a quality improvement project. There might be other examples where we just don't have any idea. So it could be maybe a budgeting process where we don't, I don't know why you wouldn't know this, but maybe you don't know this, but a variety of different budgets are always coming in under or over, and we don't have a good handle on where they're at. And it's records haven't been kept very well for whatever reason, and we can't collect that. So that could be an example of where we might use quality planning if we aren't able to get that baseline data. So I'm going to turn it over to Lori Linstead because she's got a great example of how Oklahoma used quality planning for their flu process. Lori?
Good afternoon, everyone. So you've just heard Laurie describe the quality trilogy. So I'd like to share an example of quality planning from Oklahoma. In Oklahoma, we have approximately 900 vaccines for children VFC providers, which includes our county health departments. In addition to the VFC flu, Oklahoma also invests approximately $1.5 million in state purchase flu, and that's distributed and administered to about, we distribute to about 85 county health department sites who then administer to the public. We had a flu process, but we felt like improvements were needed because the process wasn't really well defined. It was very cumbersome, and it was hugely labor intensive. So the first thing we did is we looked at defining the need. And we chose to do a complete overhaul of our flu process from pre-book, which usually occurs around in March, all the way through the post-flu season, which usually wraps up around June or so by the time we get everything in and look at expired doses and that type thing. So that was our timeline. We chose to use the quality planning model for the very reasons that you've heard Laurie talk about. A defined process did not exist. The process hadn't ever been focused on as a whole. Flu, if you're part of an immunization program, then you know flu. Every year, flu is different. So it's extremely variable, just as she said in the previous slide. And so, and we didn't have any performance data to use as a baseline. So what we did is we assessed our need by talking to both internal and external stakeholders, which included like our program staff, providers out across the state, our county administrators in those 85 counties, and our immunization field consultants. So in terms of impact, what we're doing is we're going to look at this from a standpoint of a cost-benefit analysis. What do I mean by that? I mean that we're looking at, have we saved staff time and effort? If so, what does that translate to in terms of cost savings? We've increased our flu shipments this year, but what kind of impact did that have or will that have? Have we been able to manage the increase sufficiently? Did we meet the needs of the providers in our distribution methods? We'll be looking at all of those things. We will continue, of course, to monitor the data to determine the level of impact. And if there has been a change, we're going to look at implementing a QI project for the next season. And in doing so, we'll establish performance measures using the baseline data that we gather with the goal of increasing our efficiencies in the flu process and also improving the process.
Thank you, Lori. And we will hear more from Lori and more examples as we go throughout the presentation. So just to reiterate, we talked about quality planning here, and I just want to note how quality assurance and quality improvement are different. I often provide training to local health departments and other organizations on quality improvement, and when I ask them if they have quality improvement going on and for examples, many times the examples that they're providing are really quality assurance. So let's look at the difference here. Quality improvement is proactive. We're selecting a process that we want to improve, and we're focusing on the process. Oftentimes it needs a cultural shift to be able to make an improvement. It's intended to be led by staff and be continuous and ongoing. And we're not only looking at trying to hit the mark, but we're trying to exceed expectations with quality improvement. Whereas quality assurance can be very reactive and looking after the fact. We're looking at that data. It's oftentimes led by management, but not always. Sometimes it's only that periodic look back instead of continually looking at that data. Many times it's based on a regulatory requirement, usually by state or federal law or our funders. It might be only to meet a specific standard, so it's kind of black or white, pass or fail. We're not looking at degrees of where that improvement is. And many times it's just responding to a mandate or some sort of fixed schedule that's been in place and been imposed on us. And then the last thing is that it works on problems after they occur, as opposed to looking proactively at where can we do better? Where can we do even better than we already are? So those are some of the differences. We spend a lot of time in quality assurance because we need to look at inventory, we need to count numbers, we need to collect process data, and many of those types of activities are focused on quality assurance. And the quality improvement is looking at data, continually monitoring data, and finding out and looking for opportunities for where we can do even better. Where can we be more efficient? Where can we be more effective? Where can we produce better outcomes? Okay, so let's take a look here. Where does your agency or program area spend most of your time? Is it in quality assurance, quality improvement, quality planning, or are you about equal time in all three areas? So if you nod it off for a few minutes, join us back and answer questions here. Looks like we're getting up to 100. Let's see if we can get back up there to about that 170, which seems to be a nice sweet spot for us. Keep them coming in. Starting to slow down a little. Okay, let's see what we have here. So again, 45% about spend most of their time in quality assurance. We have about 20% in quality improvement and 11, 12% in quality planning, and then 22, 23% about equal time in all three. So that's great. This is very typical and common, the results here are. And I also want to mention that if you're not spending time in quality improvement, you're spending more time in quality assurance, it may sometimes be a factor of your funding and the way things are structured. So this is an opportunity after this webinar to say, where could we apply some quality improvement, and starting somewhere small. So thanks for your participation there. The next slide I want to start talking about is providing an overview of the model for improvement and the PDSA and rapid cycle improvement. So this is really going to be the meat of the presentation here. If we look here at the Institute for Healthcare Improvement, also uses the model for improvement. And we start with three basic questions. First is, what are we trying to accomplish? When we look at a process, we look at a problem, we're asking the question, what are we trying to accomplish? We're trying to increase or decrease something. What is the change that we hope to see? And that is really how we formulate an aim statement or a goal, a measurable goal. How will we know that a change is an improvement? Well, we have to have baseline data, and we have to continue to monitor the results of a particular process so we can see whether or not that's been an improvement. What changes can we make that will result in improvement? That's our work around root cause analysis, and that's where we're really digging in to find out what are the root causes for this particular issue or problem. What seems to be causing challenges to this process? That if we made an adjustment, we made a tweak, we implemented a particular solution, that we are going to yield better results. And that could be counted quantitatively, numerically. We'd be able to understand that. So we spend our time in this first part with the model for improvement in really the planning cycle. So that's the P over in the right-hand corner. We're looking at what's our measurable goal, how are we going to know that a change is an improvement, so collecting our baseline data, studying our baseline data, thinking about how we could measure in the monitoring the effort, and what changes we can make that will result in an improvement. The PDSA cycle we usually do multiple iterations of. One iteration of the PDSA may produce an improved set of results, but multiple cycles of the PDSA may really take us to reaching that target or that goal. So if this process and this model is designed to accelerate change, we're testing one improvement at a time. So when we look at the PDSA cycle for learning and improvement, and that's really how it's intended, and I appreciate that Randall posed a question in the chat log previously before we started saying, you know, are there places where we can see programs and quality improvement projects that have been implemented across agencies so we can see what's out there. And the Public Health Quality Improvement Practice Exchange, PHQIX, PHQIX.org, is a compendium of quality improvement projects that folks like yourself have submitted to say, here's some samples, here's how we worked through it, here's our results, good, bad, or ugly, here's the tools that we used, and it really is a nice way to be able to study and explore and browse a variety of different projects. So in the PDSA cycle here, we start in the planning cycle, and that's where we're really defining that question. We're answering what is it we're trying to accomplish. We are identifying questions and predictions, so we're developing sort of our hypotheses of what we think will happen. And then we are planning how we're going to carry out the cycle, planning for data collection, etc. The do cycle is when we are actually going to implement a solution. We're going to test a solution. We're going to test one intervention. We're going to observe the implementation of that and begin analysis of the data that we're collecting on that. Study cycle is where we are completing the analysis of the data. So we now understand if an improvement has been achieved or not. We're looking at what degree that improvement may or may not have had. We're comparing the data to our predictions from our planning cycle, looking at our hypotheses, and summarizing what was learned. A big part of quality improvement is really capturing the learning that can be shared with others. And that's why tools like the Public Health Quality Improvement Exchange are so important, because it's a way for us to pass on this learning throughout the field so that we can try an intervention that someone else has tried and shows that it works. We can build best practice for our field. The ACT cycle is where we're answering what changes are to be made, what did we decide worked or didn't work, and what's our next cycle? Are we going to test another solution? Are we going to test another tweak? So we'll look at this in just a little bit more detail. And this visual that you're seeing right here is adapted from a great article, The ABCs of PDCA, developed by Grace Garenflo and Jack Moran. And I highly recommend this article as a nice introduction to quality improvement and for you to share with your staff. So we're going to go through this flow chart and be able to see each of the steps in PDSA. And there are some places where people may not spend as much time in each step as the other. So this is a little bit adaptable, but you'll see that the steps in the planning cycle, there are more steps there than anywhere else. And that's because in a quality improvement project, we typically spend more time in the plan cycle than we do in any other aspect. So that's why you see so many steps. It's really important that we take the time to explore the actual problem, to collect data on the problem, and to develop a sound improvement theory. Okay, so let's look at the first place and just sort of pick this apart a little bit. The very first step in the plan cycle is identifying and prioritizing opportunities for QI. We have opportunities for quality improvement all around us. I'm sure you can think of a million little thorns in your side within your office, within your department, within your home that you think need improvement. And so starting with your team and saying, let's brainstorm possible QI projects and topics and see what we come up with. You know, what are some of the things that really irritate us the most, that are causing waste, that are inefficient, that are ineffective? What are those processes? I want to select just one problem to address, and I always encourage people when they're starting their first QI project to pick something smaller, pick something manageable, and pick something that people can really get their arms around. Now that might be why it takes so long to get a vacation time request processed. It might be why it takes so long to get a travel expense reimbursed. It could be something very simple that affects a lot of people, or it could be something that is more specifically related to a health outcome that they're working on, like why they've had low retention in their smoking cessation class, why they have had no-shows for their clinic appointments, etc. So you can see a list of examples here on the screen. Might be inaccurate data in reports, overspending or underspending a budget, failed inspections or compliance tests, long customer wait times, no-shows, etc. So there's a variety of different things, and these are some things that are usually a little bit more simple to start with for a QI project. So we select a project, we've narrowed it down to one, and then we're going to develop that measurable aim statement or measurable goal. So we want to express the one change we're seeking to accomplish with this project in a SMART objective. We're looking for an increase or decrease in what percent, what numeric value, in what specifically, by whom, by when. So it's a very, very simple, straightforward, standard objective. And anytime you're looking for a template to write an objective, this is a great template here. Measure of change, in what, by whom, by when. So I always use that tool. So we develop an aim statement, and anyone who's been involved in QI can tell you that we develop an aim statement, and we typically have multiple iterations of an aim statement. So let me show you a couple from some colleagues at the Chicago Department of Public Health, where I have helped facilitate, we're on our 5th Learning Collaborative. And with the Learning Collaboratives, we have 4 or 5 teams who are implementing different QI projects. They come together as a learning collaborative, and they have assignments due each month. And this is a way to help them stay on track, have some consultation and training, have some peer feedback, and complete a QI project in a defined amount of time. And in this instance, it's usually 6 months. So here's a couple sample aim statements in the SMART format that they've used. The first one is that they will increase the percent of youth ages 18 and younger who will receive preventative dental exams and referrals from 14 to 30%. That was a great project with a lot of success. And then another one that has also proven to be really effective related to our friends at AIM is to raise 1 or more doses of the HPV vaccine coverage levels among 13 to 17-year-olds in vaccines for children clinics, which they had 26 of, from 38% to 50%. And I think one of the things that's important to note in relation to this second AIM statement is that the reason they were specifically trying to raise 1 or more doses of HPV vaccine was because the uptake on that vaccine was not as high as the other vaccines for the same age group. Okay. So the next step in the process, we now have an aim statement. We know what we're trying to do. We need to look at the current process. What is the current process? And describe that current process. Now, even when we do a project that is simple as how do you request vacation time, how does a vacation slip go from being a dream in your head to being approved and processed by your supervisor? If I do that in a small organization with, say, 30 people, I guarantee you there will be at least 3 to 5 different ways that people think of that process and different ways that people use that process. So it's really important that people come together and on this quality improvement team, and this is a team activity, and define the process. So a workflow analysis, a workflow diagram, some sort of flow chart where we're listing all the steps, we're listing all the decisions, and what happens as a result of the decision. Which path does that process go? All of our work, everything we do is processes. We have multiple processes. We engage in multiple processes a day. And what we need to do is come together to define what is the process now. Get on the same page about what it is now, not what it should be, but what it is now, and label that out. So that's describing the current process. And this might be a sample of what one might look like. This happens to be an example in swim lanes where you can see the different pieces of it. And I'm not going to go over this in detail, but you'll see that this is mapping it out. It's a really easy activity that you can do with Post-it notes to lay it out and use a simple rectangle for actions or steps. Use a diamond shape so you can turn a normal square Post-it note on its side to make a diamond for a decision. You can use arrows to draw which direction it goes. So it can be really simple to do that and just sort of map out those steps and make sure everybody agrees on it. The next step in the process is that we've got to collect data on the current process. What is this current process already reporting? What are the results that this is reporting? We want to be able to collect and analyze data that helps us understand where we're at in relation to the measure that we put in our aim statement or that measurable goal. What data do we already collect or can we collect fairly easily to help us define that problem that can serve as baseline data? So in the example about the HPV vaccines, we're looking at what is the current rate of those vaccinations. But there might also be other pieces of data that we need to collect to better understand the problem. So let me take a look with you at the next slide. The next slide talks about the Pareto Principle. And the Pareto Principle tells us that 20% of sources are usually causing 80% of any problem. So when we are collecting data or we are trying to understand what's contributing to clinic wait times, what's contributing in this example to fewer clients in a particular clinic receiving HIV tests, we could make assumptions, we could guess, we can brainstorm, but if we collected data on this by simply doing a follow-up survey or a survey with the clients for this particular clinic, and we said, what is the reason that you did not seek an HIV test? And we're trying to understand that. When we ask them and you quantify those responses, you'll see that not offered was ranked the highest, or the client did not want one, or it took too much time. There were language barriers, or they were unable to return to take the test at another time. Any of those responses, and it could have been a variety of other things. What we're looking for here is what are the 20% of sources that are causing 80% of this problem. If we can quantify and understand what the 20% are, and we can find solutions that will address those 20%, we're going to be able to get the biggest bang for our buck. So if we spent our time focusing on people who are unable to return at a later date and have the testing done then, we wouldn't be getting the same payoff as simply addressing the greatest couple causes here. So what you want to try to do is, when possible, be able to quantify those causes so that we're not just shooting in the dark and making an assumption about what cause is the greatest one. So if we were looking at clinic wait time, we might be looking at what is causing the clinic to break down, to go slower, and to be able to use some observable data to quantify and capture that. So on one particular day, maybe it's somebody who comes in with a broken arm and can't write, and someone has to go through the form with them and write it and record down everything for them. And that is an unusual circumstance. That's not going to be the norm. But what are the things that are more of the norm that are going through there that are causing the clinic wait time? And we want to be able to understand how much time that is happening. So that's a way that you can really flesh out that process map, put some times to it, and understand what's really going on in your process. Okay, the next step in the plan cycle is we've been identifying all these possible causes. You'll see that this is a little bit out of order here, 24 and 25, slides 24 and 25. The Pareto chart was being able to quantify those possible causes. But when we're identifying possible causes, we can use a variety of different tools that really engage staff, engage stakeholders, engage a variety of folks who can come together to solve this problem by using tools that keep people focused on the issue at hand. The tools can be helpful both in understanding the problem, but really maintaining that focus. So sometimes we use an affinity diagram where we're using all of those Post-it notes to have everybody identify what are the major causes, or what's causing this particular problem, why are people late, whatever the question is that's our problem. And give everybody 3 to 5 Post-it notes, and they're writing those down, and then we group the like ideas. That's affinity diagramming. And what's so neat about affinity diagramming is it gives everybody voice. And then people start to see the commonalities. But we also get the unique ideas that come from people that may not have surfaced because they were just talking or brainstorming and letting 2 or 3 people in a group talk. So from the affinity diagramming, we can also form categories. And those categories might be, these are process problems, these are equipment problems, these are cultural or environmental problems. And those might become sections that would be really helpful on another tool like a Fishbone diagram. So let me just advance the slide here and show you a sample of that. So this is a cause and effect diagram or fishbone diagram. And here for the HPV vaccine coverage project that I had in Chicago, where the HPV vaccine was not increasing as much as Tdap and MCV vaccine, they were looking at what the reasons were. So they were, based on this program, they go in and they give feedback to the providers on what the data is showing, and they hold these feedback sessions. And so they were looking at what are all the potential root causes of why this is not happening. So they had some that were process-oriented, the fact that the follow-up was limited, the feedback and messaging was not HPV-focused. There were some policies that were impacting that, where HPV vaccines were not required for school entry like other vaccines. Insurance coverage was inconsistent. There were also some that were related to parents that maybe they didn't consider HPV a priority. They didn't understand the need for it. There were some that were resources related and some that were provider related, provider biases, provider misconceptions, providers uncomfortable making HPV recommendations. So these were all the root causes they identified. And prior to getting to this point, they likely did an affinity diagram that helped them identify what are these big categories, what are some of the issues, and then used that information from the affinity diagram to populate this root cause analysis. So the point is using some really simple tools that will help you stay focused, help you dig deeper into understanding the problem. You can also use other tools like the 5 whys. So let's say, for example, under processes, the feedback messaging is not HPV focused. Well, why is that? We could use the 5 whys. And maybe we say because we're spending more time on Tdap and MCV because that's what the providers are asking about. Well, why is that? Because they're not comfortable talking about the HPV or whatever the case may be. But we're digging down into the 5 whys to get to a root cause. So those are some tools that will be helpful in helping you explore that. And you can also look at YouTube. You can look at PHKICS. You can look at a variety of places where you can see how people in real time are using these tools. So that can be really helpful. So we end up needing to narrow this down to identify potential improvements. We would have to select one of those root causes to be able to say, what are we going to do to identify a potential improvement? We can't focus on all of these things. And in this particular example, the team looked at where do we have the greatest control and influence? We don't have influence over some of these issues. So where do we have influence? Where do we have control? And then they selected one area that they wanted to focus on. So you're identifying a potential improvement. You might use prioritization tools to prioritize those improvements. But at any rate, you are selecting one improvement. At that time, you're revisiting your aim statement and seeing if anything needs to be revised or seeing if you maybe need to add a short-term measure to also be monitoring. Following that, we usually develop an improvement theory. So we know what the root cause is that we're working on. We know what the solution or the intervention is that's related to that cause that we want to test. So we develop a simple improvement theory. If we do this, then this will happen. Okay? And then finally in the planning cycle, we want to develop a detailed action plan for who's going to do what when to test this intervention. And that would not only include the implementation of that intervention or the solution that we're testing, but it would also include how we're going to measure and monitor the results. So I'm going to turn it back over to Lori, and Lori's going to give us an example of their child care project and what they did with that project.
Okay, you've received a lot of information, and so what I want to do is take you through the Oklahoma, one of our quality improvement projects that was built around child care, so that you can take the pieces, the components that Laurie's been talking about, and apply them to a real-life scenario. And so the first slide I want to show you is before I discuss our QI project, I wanted to show you this because it tells you why we started to look at QI in Oklahoma. When the National Immunization Survey results were released to states last year in September of 2013, so go back with me another year, back to 2013, that's when we learned that our coverage levels for the childhood series were at 61%. And the United Health Foundation then, in turn, ranked Oklahoma 48th in the nation for coverage levels for children 19 to 35 months of age. And you can see here on this chart, this graph, where we were, Oklahoma, what the U.S. national ranking or rates were, and then how that compared to the Healthy People 2020 goals. This, it was completely unacceptable. And we as a program area began to look at how we could impact those coverage levels. What could we do? We knew we could do better in Oklahoma, but how? And so we began to have those discussions. So we started really with just a simple question, and we asked ourselves, how can we raise our coverage levels? Were there opportunities, and if so, what were those opportunities? And so this led us to look at our current process around child care immunization record audits and how to impact compliance within those licensed child care facilities. To give you just a little bit of background to set this up, Oklahoma's Child Care Immunization Law and Child Care Licensing Act require all children enrolled in licensed child care to be up to date on the ACIP recommended childhood immunizations, or they have to have an approved certificate of exemption on file. And just on a side note, Oklahoma is one of those states that allows an exemption in all three categories: medical, religious, or personal/philosophical. So the immunization law is the responsibility of the state health department. And the enforcement of the Child Care Licensing Act is the responsibility of the Department of Human Services, where Child Care Services resides. They're the ones that license these facilities and regulate them for compliance. So Oklahoma has over 6,500 licensed facilities, and that equates to about 142,000 children in child care, ages 6 weeks to 12 years of age. That's a lot of kids. We discovered that for 2013, the overall compliance in terms of up-to-date record cards, immunizations, or exemptions on file, overall compliance in the child care facilities was at 77%. So we identified that an opportunity existed to go in there and to directly maybe impact overall coverage levels for children around the 431, 331, for childhood series by ensuring that all kids enrolled in licensed child care were up to date on their immunizations. So we developed an aim statement that was built upon the components of the SMART objective that you heard Laurie talk about earlier, being specific, measurable, achievable, relevant, and time-bound. And so we were looking at what could we improve, what was the one thing we were seeking to improve, and that's how we began to develop our aim statement, which you can see here on the slide in front of you. It was by December 31st, 2014, to improve overall compliance of child care facilities by 10%, from the 77% that we had discovered to 87%. So we followed then the PDCA model in our QI process. On this slide you see that we developed an improvement theory, and that improvement theory was that if children ages 19 to 35 months enrolled in licensed child care facilities are up to date on the 431, 331, childhood series, then it makes sense, one would think, that overall childhood immunization coverage rates in Oklahoma would then improve. So this led us to develop an action plan, and that action plan involved our immunization field consultants to perform child care record cards in their assigned counties, record audits within their assigned counties. So why did we choose this intervention strategy? Why did we go with this action plan? We chose it because we felt like this was something that was within our control that could improve the overall compliance and therefore impact coverage levels. So we began by flowcharting. We began by flowcharting out the current child care facility record audit visits that are conducted by our field consultants. And you see that flowchart that's in front of you right now. The next thing we did is we did a force field analysis. We did that to determine the positive factors driving us as well as the negative factors restraining us from the aim statement that we had developed, which, if you'll remember, was to increase overall compliance within the child care facilities. We did an affinity diagram, and that was done to find the main cause and possible solutions as to why were our child care facilities non-compliant. They weren't even at 80%. What was going on out there? So we did the affinity diagram, and then we moved on over into the fishbone. So this led to the development of the fishbone diagram to identify the root cause. The root cause of the problem, what was going on. It was important for us to focus on the things we had control of or influence over. So if you notice here on this slide, there are 3 boxes highlighted in red. What those say is that the VFC leadership was not enforcing policy. So we were not, that means my office, we were not enforcing the policy, the immunization law. There were no consequences for noncompliance within the facilities, and there was no relationship with DHS, who is our enforcement agency. So by recognizing these key pieces, they've been addressed in our work that's been done during the QI project, as well as the work we'll continue into 2015. So we started this project in January of 2014, carried it all the way through December, and now we're taking the lessons learned and the work that we did around that QI project, and we're moving it forward currently into 2015. So what does that include? This includes a new process, includes new policy and forms with our field staff, and we asked for them to be involved. They helped us develop our policies and our forms. They were actively involved in that. If they're going to be in the field out there doing the work, they know things that are happening out there. They know things that work, things that don't work, so we actively engaged them and involved them in that process. We began to build a relationship with the Department of Human Services and provide education to our child care facilities to begin to enforce that compliance piece. Okay, the next thing, lastly, is a prioritization matrix. This was completed to assist us with sorting through and the prioritizing the items that could improve effectiveness of the project. So the next slide goes back to the PDCA cycle.
Great. Thanks, Lori.
This moves us into the do part. So that first part that I just talked to you about was all about planning. We had to put all the planning pieces in place, and then it will lead us to the next piece, which is the do cycle.
Lori, I'm going to let you just keep going because in the do cycle, you know that you implement it, you're collecting data, and you're going to tell us a little bit about the results that you did see.
Okay, we'll keep moving. So under do or implement, we were then ready to go ahead and develop our action plan and to begin the implementation process. So in developing our action plan, we outlined a process that required our field consultants to perform 1,000 record audits for children 5 years of age and younger in those assigned counties or assigned regions of the state. For those facilities that had less than a 90% compliance, we instituted a plan that required our field consultants to make a follow-up visit to those facilities within 2 weeks. If the facility in question was still at less than 90%, the field consultant then would contact my office, the central office, And then we would determine whether or not to make a referral to the Department of Human Services for the enforcement piece, because we had worked with them, we had been out there for a follow-up, we were not finding success. So at that point, do we make a referral to DHS? We had discussions with the Department of Human Services to develop those lines of communication. We met with them, we stayed in contact with them. We learned who their licensing representatives were across the state so that our field consultants could begin to get to know them. And we developed the DHS for enforcement of that law. Reviewed our current policies and our procedures, our protocols, and then we began to analyze our process for the record audits. And so then we looked at the data collection. Okay. So
all right.
Move over here to the data collection piece. There are several things that we found. In our data collection, when we're doing the check process, the PDCA, the check process, we noticed several things. First of all, overall compliance increased to 86.3%. You'll remember our goal in our AIM statement was 87%. We just missed it. I like to round up, so I think we were right there, which was really a great improvement. Really proud of our field staff and our providers, our child care providers out there that were working with us. We discovered fewer record audits were performed in 2014 as compared to 2013. But we've attributed that to the fact that we had several vacancies with our field consultants. And so we weren't able to get to the numbers that we wanted due to those vacancies. What were some lessons that we learned? Lessons learned is our immunization service staff, they were completely new to the QI process. Never had been introduced to it, did not know anything about it, brand new to it. We also learned that it's vital. You have to determine what the root cause is. That's key to this. We had inconsistency in our data. It was essential to develop partnerships with our state licensing and enforcement agency, which was the Department of Human Services, because they were the ones that were working with us in collaboration, hand in hand, in order to ensure that this was happening out there, that kids were getting up to date on their shots, those record cards were coming in. That's a licensing regulation in Oklahoma. All of these pieces or components had to be in place, and we would not have been able to do that without the partnership and the cooperation of DHS. Our child care staff out there within the facilities, they were unable to interpret the immunization records. The schedule is difficult when you look at the intervals on there, and if you get off track with shots trying to apply a catch-up schedule, it was just very difficult for them to interpret the records. We lacked a standardized process to know which facilities were being audited. We didn't have that process in place. And we had competing priorities for our field consultants. I know that you understand that. There's so much going on, and there's so many things that require attention, and we were no different. We had those competing priorities. And we had a need for uniformity in reporting among our field consultants. So you can see over here to the right-hand side then the baseline data compared and how we were able to move that marker in doing the things that we did and trying to impact those rates. I'm going to skip over here to this slide that moves us into the part of the PDCA, which is the ACT. And we looked at adapting. So what are our future plans? What changes need to be made as a result of this QI project that we did? Well, a new process for record audits, for one thing. We learned that we need to have the inclusion of the educational component for our child care facilities and educating them around the need to comply with the immunization law, the Licensing Act, and also, in looking at those record cards, We're not asking people to understand the entire immunization schedule all the way down to the footnotes. If you've ever seen one, then you know what I'm talking about. It can be quite overwhelming. But how can you look at a record card and determine where a child is before you enroll them and accept them into your care? We revised our employee performance review for the field consultants. We tightened that up a little bit and made it more clear as to what the expectations were for our field consultants. We continued training and assistance, and we will continue training and assistance to our field consultants. We knew that we had some training issues of our own here, that we learned that. It became very clear. And so we've implemented training and assistance, and we will continue that. And then looking at a joint follow-up plan for non-compliant facilities, those child care facilities, and that joint follow-up plan between the State Department of Health and the Department of Human Services, and how we can solidify that so that we are both working together. The next slide, which is actually my final slide, this is a storyboard. This gives you the information of our QI project from the beginning to the end. And it lines it out so you can see that planning, the implementation, which is the do, the check, and the act, the PDCA. So this was constructed at the completion of our 2014 project. As you look at this, and I know that it's hard to see on here, and so I'm happy to share this in whatever way is feasible. You'll have the slides and everything, and if you have questions, I'm happy to answer questions. But as you look at this, I want to...
And Lori, this is Lil. We also posted a link in the chat box so you can access that storyboard. And just another note, we are going to go over our time, so we understand if you have to hop off the line, but we do want to continue this. Back to you, Lori.
Thank you. There's just a few things I want to leave you with, things that I'd like for you to consider that we learned. One of those things, as I mentioned earlier, was that this process was completely new to our staff. Absolutely new. They had never been introduced to it before. I think perhaps really out of our entire service area, there was maybe only a couple of us who had ever really heard of the quality improvement. We decided here in Oklahoma early on that our goal was to complete a full PDCA cycle as a team, from the beginning to the end, this whole cycle that you see up here. And to work towards achievement of this goal while managing our current duties. We were committed to getting through this process. And in order to do that while managing our current duties, we decided to implement only one PDCA cycle during this project. Why? For all of the things I just told you, we had competing priorities, we had things going on, but we knew we needed to do this. Our rates were terrible in Oklahoma. 48th in the nation is just awful. And we knew that we had to do something, but we knew that we had to balance that, as I'm sure all of you out there have to try to balance within your own organizations. For us in Oklahoma and our team, it was more about the journey. It was more about learning about QI and going through that process, that journey together. And that was our commitment. That was what we were focused on. Let's learn this. We've got to try something because what we've been doing in the past is obviously not working. So let's just give it a shot, but let's be committed together as a team. And so I want to leave you with this, and I believe this journey's taught us many things. The first thing, probably the most important thing, is that change is very, very hard. It's so very hard, and trying something new is really frightening. But it's okay to take a chance. You have to be willing to take a chance if you ever hope to see change within your organization, within your service area, your program. You have to be willing to step out there, even though it's frightening and you're going to get pushback from your staff. There are going to be days that you go home yourself and you think, what have I done? What have I started? because it can be overwhelming because it's difficult for all of us to think about something new. And you need to know going into this that you're not going to be perfect. It's okay not to be perfect. The important thing is that you're giving it a shot and that you're trying. It's not always about the process. It's just sometimes about that journey. So I want to leave you with this one thought, and don't be afraid to give this a try. You might be really, really amazed, as we were. You might be amazed about what you discover about your program, and you might be really amazed about what you discover about your staff along the way. So I would encourage you, give it a shot. Give it. If Oklahoma can do this, I promise you can do it too. Thank you.
Thanks so much, Lori. I really appreciate that. And we have a question posted by Sonia Lewis. Were there any best practices that came out as a result of the project that you'd like to highlight that you've noted as a best practice now?
Oh, we have. We've learned several best practices. We've learned, in terms of how we go into those facilities, how we approach them, what we do in advance with our prep work in going to those facilities. I cannot express to you how important it was to set up that relationship with the Department of Human Services. One of the key things that we learned is that our staff were having trouble getting into facilities because facilities would say, no, I don't want to have that record audit today. Thank you very much. No, there's an immunization law out there, and we need to get into the facility to help you. See, that's our role, is to be the helpmate, to help them to serve as a consultant. DHS is the enforcement. So I can tell you that there were a few times during the QI project, I had to pick up the phone and call DHS to say, we're not getting into that facility. And within literally less than 30 minutes, we would get a call saying, you're in, go. So I can't tell you how important that was. And looking at those record cards, figuring out what we decided, the best practice, I think the most important one I can share to you is keep it simple. We had so much paperwork, and we were asking our field consultants to do things that were way over the top. And why? And so when we really began to break it down in this QI project, we asked why? Why are we doing all of this? And so by involving our immunizations field staff in this process and really knocking down that process to very simplistic steps has just made an incredible difference for us.
Thanks, Lori. And I think you're continuing to monitor the data, and as you said, you're continuing on the improvement journey. And so documenting those best practices so that they're available to share with others will be important, and I'm sure you're considering, if you haven't already, submitting your project to the PHKICS as well.
Yes.
So thanks again for sharing. So just to wrap up, we have a few slides we'd like to cover and then answer any questions if we can. I do want to mention, Lori said that they made a decision in that year of 2014 to complete one full PDSA cycle from beginning to end. And that is really a feat. That's a major accomplishment, particularly at the level that you were looking at a project. The rapid cycle PDSA is recommended to increase knowledge and experience and to be able to hold the gains of what they have been able to identify as improvements. So Lori talked about the improvements that she's been able to make right now, and she wants those to continue to grow. So it's going to be important that they continue on with PDSA cycles to reinforce and to continue to see improvements. So for the PDSA, when they looked at root cause analysis, they identified many different causes they could address. They also identified many different potential solutions, and Lori summarized some of those. They can now start on another solution to do another PDSA, and perhaps in more of a rapid cycle. So that was a long project to do the planning, doing the testing, the studying, and then acting, and they chose to adapt their intervention. And now they might have a solution that they're going to make just a small tweak or one small process change, and they might be able to test that in a smaller quicker scale. They might do it in just a couple of the centers and not all of them. So we did have someone make a comment around some experience that they have where they have worked in a facility where they were doing much more smaller rapid cycle changes over a very short amount of time and doing multiple PDSAs, and that's really the intention behind rapid cycle. Not everything works that way or the data would be available in rapid cycle. There are some programs that I've worked on in increasing the redemption of farmers market coupons that they couldn't get the data for almost a year. So doing rapid cycle wasn't going to be as helpful to be able to show whether or not it was working. We might have just been implementing a bunch of solutions if we didn't wait for that data. So it's really dependent on the type of project and how quickly you can get that data to see if the changes you're making are really the improvements that you want to make. The intention, though, is to continue implementing PDSA cycles until you've been able to get into that quality control zone and you're where you want to be with the data. You're satisfied. It's reached a threshold where you're satisfied and you're maintaining those results. And then you're going to continue monitoring that and then as needed apply quality improvement to get that back on track. So that's really the goal is with the rapid cycle improvement and multiple PDSA cycles. It's short cycles. It's really a very iterative process designed to hold the gains and to continue with improvement and testing multiple interventions. So when we do this on the first round, we're usually testing one intervention at a time with our planning cycle, and then each round of a PDSA is where we're testing another intervention. So the time that you spend in the initial planning cycle may be decreased in the other PDSAs because you may have identified those potential other solutions in your first planning exercise. Let me go through really quickly with just a few other slides. I want to talk about the principles of quality improvement because I think these are important underlying foundational components for starting QI. The first is knowing your stakeholders and what they need. The voice of the customer is very important. The most progressive view of quality is that as defined by our customers. So if we're talking about wait time, what is an acceptable amount of wait time to wait in the clinic? If we're talking about how long it takes for someone else to get the report that they're waiting on within the office, what is a feasible amount of time? So understanding what the voice of the customer is. What is the threshold for the data that your funder expects you to achieve with a health outcome or with another performance measure? What are those stakeholders' needs? And then set your target, set your goal based on those needs and your baseline data. The second principle is that we focus on process, not people. We are trying to improve the overall process, and it may be improving at one piece of the process at a time. But again, we go back to some quotes by Deming and others who were founders of quality improvement, that 85% of poor quality is a result of poor work processes and not of staff doing a bad job. So in quality improvement, we are focused on studying and improving the process, not people. We know that when we map out a process, whether it's through a flowchart, a process map, even a walkthrough, if you walk through like you're the piece of paper or you're the work going through the clinic flow or whatever the case may be, you walk through that process. When we see places where there's a handoff, that's often the places where a process can get jumbled, can go wrong at the point of that handoff. Not everybody gets the pieces of it that they need. So we really want to understand what that is. The other thing is that we have some extremely complex processes for things that could be really simplified, and I think Lori did a great job of explaining that there's so much complexity to what they were expecting to be done when it may have been able to be simplified. And the reason we get to those complex processes is sometimes just because there's a workaround. There's been a new requirement that's come in. Maybe someone else has taken over and decides we need a certain piece of paper. Maybe someone went on paternity or maternity leave, and we need to add in someone else doing it, and they're not skilled in all the areas. So it becomes a workaround. So a really simple process that we thought should be simple and pretty cut and dry has become extremely complex. So spending time in making sure that everybody comes to the table and focuses and defines the process as they see it, really that learning alone is so beneficial. So even if you can't do a full QI project, using some of these tools really helps you to understand, problem solve, and make some improvements. So I want to give you an example of my colleagues in Illinois at the Kane County Health Department, how they learned that it's process and not just people. So for their public health emergency response program, they had noticed that they had a pretty sharp decline in employee call-down response rates in October of 2010. And if you're looking here at the bar chart on the screen, you'll see that results were pretty steady, with the blue bars being the people who acknowledged the call and the red bars being available to assemble. So we had pretty consistent rates until October of 2010, where they sharply declined. And when we see that sharp decline, remember again, this was in quality control. We were monitoring the data in quality control. We see that sharp decline and we know we need to go to quality improvement. So they made some assumptions that were pretty fair assumptions. During this time, the health department had gone through some major changes and was getting ready to lose over 60% of their staff. So it was not surprising to make an assumption that perhaps the response rate was due to, the climate, the culture, what was going on in the organization, and people, perhaps not responding as they normally would have. So that was a pretty likely expectation. However, the team in King County, very experienced, very smart, have a great QI project and program going on there. They realized we really need to look at the system. So they looked at the system after doing a mini assessment and finding out if people really were responding to the call down drill. And people were saying that they were, but the data wasn't showing that. So when they dug into it, they found that the electronic system was not accurately reporting responses. So they could have had a very clear lack of understanding about the problem if they had not got engaged in problem analysis. If they had just gone with their assumptions, they might have sent a nasty memo out to staff saying, we need you to respond to this or what have you. But instead they looked at the system. They looked at the process, not to the people, looked at the process and found that there was a glitch in the system. So they were able to fix that, and what you'll see from that decline in December 2010 was that they not only saw an improvement, but they saw a sustained improvement that's actually by October of 2012 had reached 100%. So they had marked improvement. So that's an example of where we focus on process, not people, even when it's easy to do. The other principle that I want to focus on here, or next one, is using data for decisions. So we use data to, performance data, to target our improvement. We use it to understand the baseline of where we're starting. And we also use it to say, if we're starting here, and then where is it feasible that we can improve? How far can we improve? What can we do to make an improvement? You use data to analyze and understand what the problem is. Remember the Pareto. We're looking for those vital few of what would make up those 20% of causes that are contributing to 80% of the problem. We really analyze that data to understand those root causes, and of course we use the data for monitoring performance outcomes. So data is a necessity in quality improvement. We're not just trying to make change, we're trying to make measurable improvements. Here's an example of a program that I worked with in Chicago using data throughout the quality improvement process. So this particular program had an aim statement of their HIV prevention program decreasing missing data variables from 39% in 2012 to 10% by September 2013 and 5% by January 2014. So they were looking at data that's submitted from agencies who are carrying out HIV prevention programs, and they had to use data to target their improvement, to identify the root causes. They conducted a customer survey. They looked at the percent of clinics who were using the Excel reporting forms that they have. They used data to monitor performance outcomes. What was the rate of uptake with the new reporting form? What was the rate of the percentage of missing data associated with new reporting forms, et cetera. So there were multiple places where data was absolutely critical, and this happened to be a project that was focused on data as well. So the next principle is using teamwork to improve your work. And Lori did an excellent job of explaining why that teamwork is so important. Getting the folks who are on the ground, boots on the floor, doing this work engaged in the process. Getting the Department of Human Services on board and building that relationship and working together. That teamwork was so essential for a successful project. Quality improvement is not intended to be done by senior managers alone on every project, but really intended to be who are the people who are involved in this work? Who are the people who are impacted by this work? Is there someone who could offer a fresh perspective who's not as ingrained? Maybe it's somebody newer to the program or newer to the agency. Are there stakeholders like other organizations or even clients who need to be involved in the team? So really having teamwork to improve the work come together, to share labor, add to creativity, and knowing that the reason we want to do this and engage other folks and even work cross-departmentally, cross-functionally, is because our processes usually cross multiple functions. They usually don't stay in one organization, one department area, or with just a few staff. They usually move around. And we know that the solution generally affects many. And since we are not crazy about change, what we want to do is say the people that this change is going to affect, let's get them involved. Let them help identify and understand the root cause so that when we're selecting a solution and they're part of selecting a solution, they also understand that it's really tied to that root cause. It's not just an arbitrary change. So teamwork is essential for QI, and I really encourage teams to make a team charter so they can be on the same page with that. The fifth principle is making quality improvement continuous. So Lori said, we did all we could do for 2014. We wanted to get through one PDSA cycle, and we did that. But we want to be able to make this continuous, and that we need to continue monitoring that data, enter and address multiple rounds of PDSA as we can, but continue monitoring that data at a minimum. The sixth and final principle here is demonstrate leadership commitment. Quality improvement, to be really supported and really successful, needs leadership support. QI teams like to and need to have a champion, someone who can help remove barriers when they come across a barrier, someone that can help them if they need authority in making a decision or allocating resources to help support an improvement that they want to test. They need to see that their work in this area, because it's extra, it's adding time to what they're doing, that they're rewarding and they're able to communicate the improvements that they're making. So leadership can really provide the support of making sure that people have the resources that they need, that maybe they're building some expertise through training or consultation or linking them to the many resources that are out there. They're helping to remove those barriers. They're supporting the quality improvement principles by saying, yes, a team is important, a cross-functional team is important. They are helping to make sure that quality improvement becomes threaded through the infrastructure of an organization. So leadership commitment is very important to sustain quality improvement. With that, I'd like to just wrap up with a couple poll questions and share some resources with you. So from this very basic introduction, which is what it was intended to be, are you interested in learning more about quality improvement? And let us know there. We've got one person that's saying, no, I think I've had quite enough. And several more who are saying yes. We'll keep that going right now and close it out in just a moment. And if you are interested in learning more about QI, make sure you note specifically what you'd like to learn more about and include that on your evaluation. So about 95% of you are interested in learning more, and a little bit less, definitely less on unsure and don't know. So let's look at the last and final poll question. As a result of this session, are you interested in participating in a QI project at your agency? You want to give it a shot. I know Lori and I are really passionate about QI, but it doesn't translate to everybody. We hope that it does and that this has made it interesting to you, and you hope that you can try a QI project now. So let's go ahead and close that out, Lil, since we're running short on time. And, oh, that's great. That makes my day. 92% of you are, and 7% are unsure, and 1% just, no, not for me. Okay, I want to share a few, oops, somehow I got on the wrong slide. I want to share a few resources with you. They're on your screen right now, and remember you'll have a copy of these slides if you don't already, so you can click on the links or use them. The Institute for Healthcare Improvement has a great set of resources. The Public Health Quality Improvement Exchange that we talked about already has great resources. You can participate in discussions. You can post questions. You can peruse projects that people have and how they've used tools. Lil's organization, NNPHI, Public Health Performance Improvement Toolkit, has a variety of recorded webinars and archived webinars, as well as tools and samples. National Association of City and County Health Officials, NACHO, has Quality Improvement in Public Health. Someone else posted also about the Michigan Public Health Institute QI Guidebook. That's available. It's a free downloadable book that you can use that has sample projects in it and really a nice simple walkthrough. And the Public Health Foundation, PHF, has a great performance improvement learning series catalog. They also have a quality improvement and specific performance management page. So those are really great resources for you. Wanted to see if there are some quick questions that have already been posted in the chat log that we can answer. And I see here Nancy had asked, do we have examples of AIM statements that are not focused on individual services but on community level changes? We certainly do. And the Public Health Practice Exchange, PHKICS, there are multiple listed in there that I would encourage you to take a look at. I believe I already answered Pat's question. She had asked a question about the multiple cycles, so we talked about that. And Jonathan's question, what suggestions do you have for local health departments to implement solutions to problems without implementing QI projects, sort of quick fixes that aren't documented to show improvement? So, Jonathan, I think that is just the way we operate in life. We have to do some of those things on the fly, right? We don't always have the luxury of going through a formal QI project and being able to document that. What you can do is try to go back and understand, what change did we make? Where did we start from? What was the change that we made? Did it result in an improvement? Can we attribute that improvement to that change, or were there other variables that we can't really attribute it to that change? We don't know for sure. So that's one thing. The other thing is, I would really encourage the health department to try something small, bite-sized, manageable, something in an administrative area or something in a program area that's more process-related before you get to an outcome-oriented, QI project. So when I say that, I mean process-related would be improving the wait time, or improving the retention rate for a smoking cessation class, or improving the satisfaction results for a training. Those are really process evaluation, process results. But if you're decreasing the smoking rates and you're decreasing lung cancer as a result of that, those are more community, population health, outcome-based. But start small. Start with one of those pieces of the process and be able to learn the QI process that way, document it, so then you can go into something bigger. So those are the answers to the questions that I've seen that have been posted so far. Lori, Lil, are there any additional questions that we have that we can answer before we close?
This is Lil. I really appreciate you running through those. I think we're going to stop here, but we will make all the slides and the recording available to everyone. Laurie Call and Lori Linstead, I give overwhelming thanks for sticking with us through the technical issues and giving such a valuable presentation. We've been getting comments in about how useful this has been. So thank you so much. I really appreciate it.
Thank you.
Any final words of wisdom, Lori or Lori?
Just try it. I mean, really try the tools. Even in a staff meeting, if people are complaining about a particular issue, try a fishbone diagram, try a root cause analysis, try to understand what's going on related to that. The more comfortable you get with the tools, the more easy it's going to be and comfortable for people to do the project. So I say just try it.
And I would echo that. I would tell you that when we first started this, I was always saying QI, or we need to look at this, or we need to look at that. It's become common language here. I've told them they don't even notice that they're talking in that language here with our staff. So you just try it. You'll be surprised, and it'll be a great experience. So thank you for your time.
Thank you.
Bye, everyone. Take care, and look to our website for more information. Take care. Bye-bye.